First of all, I thank the organizing committee of Northeast CSI, and also I thank Dr. Manoj Agarwal sir and all my seniors for making up some time for us. And I also thank all my juniors and colleagues to participate in this program. So actually, I am presenting a case on this is a acute limb ischemia case. So 50 years old lady, she was a housewife by profession. She presented with severe pain of the left upper limb, hand, fingers, and blackish discoloration of the middle finger for last 4 to 5 days. She had a history of surgical resection of terminal ileum with temporary colostomy in the abdomen about 15 to 20 days back. And also she had history of hypothyroidism and anemia. She is not hypertensive, non-diabetic, no past or family history of similar event or any vascular event like stroke or myocardial infarction. On clinical examination, I found that the hand is cold and clammy. Up to the forearm, there is skin change, color change, that is pale, and the capillary refill time was prolonged. Absent of left brachial, radial, and ulnar pulse. BP was not recordable on the left arm. On right arm, there was tachycardia and BP was 110/70. There was sensory impairment in the hand up to the wrist, and no sensation was present in the middle finger. You can see on the photo there was a discoloration of the middle finger, distal fillings, and motor function was almost preserved. Apart from that, the power of the grip and below elbow flexion was weak. So patient was diagnosed as acute limb ischemia of Rutherford stage 2B. Blood samples were sent urgently for complete blood count, RFT, LFT, BTCT, PTI, NRA, BTT, and full coagulation profile. Immediately, intravenous 5,000 unit of unfractionated apparent bolus administered, and attendants were explained about the prognosis of the limb, that it may need amputation, bleeding risk associated with thrombolytic therapy, and patient's history was taken for any contraindication for thrombolysis, and immediate intervention with the catheter-directed transarterial thrombolysis was planned. So by that time, the platelet count came to be 950,000 per cubic millimeter, and hemoglobin was 8.4. Total count was 19,000 with myelocyte and metamyelocyte of 4 and 8% respectively. But coagulation profile reports were pending, and the patient was diagnosed as primary thrombocytosis. The medicine team and a hematology referral was sent. Oral loading dose of that's why oral loading dose of ticagrelor 180 and aspirin 325 mg administered, and patient was taken to cath lab. As the patient had supramesenteric artery thrombosis few days back, so we took a check shot there. Then through the transfemoral approach, through the right femoral artery, we take 6 pence GR 3.5, and we can see there is a large thrombus at the mouth of the left subclavian artery, and also in the left brachial artery, the whole artery is small in lumen, and the radial ulnar artery were not visible after their origin. So first of all, I tried with ballooning of the at the ostium of the radial and ulnar arteries, but I failed. There was no flow. And after that, I saw that there was a large thrombus including the whole left brachial artery, just at the mouth of the catheter. And by that time, we infused already 5,000 international unit of unfractionated heparin. And then we took 6 pence export advanced catheter and over the BMW air to suck out the thrombus from the artery. After the thrombus suction, we can see the brachial artery and radial artery completely, but not the branches. And also we can see some clots in the distal radial artery, but ulnar artery was not seen. So we used semi-compliant balloon 212 then export advanced catheter, and using the same guiding catheter with tip kept inside the clot in the ulnar artery and several holes made proximally. We went for catheter directed thrombolysis with tenecteplase 2.5 mg per 2.5 mg bolus, followed by 0.25 mg per hour infusion for 24 hours. On day 2, patient was having severe pain after 24 hours of tenecteplase infusion. So we took her again to cath lab, and it showed that there is extensive thrombosis of the left brachial artery. So then we repeated again the thrombus suction, but there was no outcome, and there was thrombus in the brachial and distal arteries. So we have changed the strategy. Catheter directed reticulous infusion was started with 5 unit bolus and 0.25 unit per hour infusion. This time we have planned for 48 hours of infusion along with interventional F6 bolus followed by 0.125 microgram per kg per minute IV over 12 hours. This time coagulation profile reports have already arrived, and those are also normal reports except platelet count. So we have infused F6 this time. And after infusion of F6 and then reticulase, you can see all ulnar and radial arteries are clearly visible, except some distal digital branches of the radial artery. You can see the middle finger and index finger. You cannot see the distal phalanges. Otherwise, there was excellent flow achievement in the radial and ulnar arteries. And in proximally, because we infused the thrombolytic only distally, so this time you see the proximal, check the proximal artery that there are some thrombus in the mid part of the arm in the brachial artery, and also in ostium and proximal part of the subclavian artery. So we continued the same treatment, and on day 4, we took check shot that all thrombus were clear, and the proximal subclavian artery was also bigger now. There is no clot except for a small clot sitting eccentrically in the proximal subclavian artery. So at 5-month follow-up, patient came with only the dry gangrene of the middle finger distal phalanx, and the same patient also presented 2 months back with bilateral lower limb DVT and acute ischemic stroke 1 week back. So luckily she arrived to hospital within 1 hour, and she received intravenous thrombolytic therapy from neurology side, and there was no neuro deficit. So this time we changed the ticagrelor to prasugrel along with aspirin, and hematologist has confirmed the diagnosis of essential thrombocythemia, which is one of the chronic myeloproliferative neoplasm, and she is under treatment for that. So the take-home message is that although none of the commercially available thrombolytic, that means alteplase, reticulase, and tenecteplase has shown a benefit of one or another, but in our case, the reticulase showed better outcome than tenecteplase. And although evidence of adjunctive use of GB2B3 inhibitor in these circumstances is not proven, but it has shown benefit in our case by giving intravenous bolus followed by infusion of F6 and catheter-directed thrombolytic and thrombus aspiration can be successfully done by using all our regular PTCA hardware to prevent limb amputation. And we should always try to find out basic etiology of arterial thrombosis, especially if it occurs in upper limb and in patients with a peripheral artery disease, and to treat the underlying cause to prevent recurrence. Thank you.